Hey, thank you everyone for joining us at this breakout session where we'll be talking about living with lymphoma in terms of neurocognitive effects after treatment. We have here with us today Dr. Lori Bernstein, who's a clinical investigator and neuropsychologist at the Princess Margaret Cancer Center, and she will be providing educational information on the short and long-term neurocognitive effects that lymphoma patients may experience following treatment. Dr. Bernstein is an expert in this field, and she will provide recommendations to better cope with cognitive dysfunction and will also educate on ways to improve functioning. Dr. Bernstein received her PhD in psychology from Columbia University in New York City and has been a licensed neuropsychologist in Ontario since 2002. Dr. Bernstein works at the Princess Margaret, as I mentioned, in the Department of Supportive Care, where she is a clinician investigator in the Cancer Rehabilitation and Survivorship Program. Dr. Bernstein is an assistant professor in the Department of Psychiatry at the University of Toronto and is also an adjunct faculty member in the Faculty of Graduate Studies at York. Dr. Bernstein's clinical practice includes neuropsychological assessment and an individual and group psychoeducational interventions designed to teach patients self-management skills to better cope with cognitive dysfunction during and following cancer diagnosis and treatment. Her research focuses on better understanding and characterizing the cognitive changes that cancer and its treatment has on people, both in the short term as well as the long term, and ways to improve functioning. Thank you so much, Dr. Bernstein, for taking the time today to be here with us and to present on this topic that is so important for our lymphoma community. We really look forward to your presentation. And with that, I'll pass it on to you.
Okay. All right, everyone can hear me? Yes? Okay, thank you so much for inviting me and for that introduction and for coming and today to hear about neurocognitive effects after treatment. First, I want to mention I don't have any financial conflicts of interest to disclose. I should mention that I am a co-investigator on a couple of research grants coming from CIHR and Canadian Cancer Society, but none of them involve for-profit or non-profit product or drug development. So, chemo brain. It's a relatively new term, and it actually has made its way into Webster's dictionary, and it's defined as, quote, impaired cognition, such as memory loss or lack of concentration, that has been observed in patients who have received chemotherapy. So even 2 years ago, it actually hadn't made it into the dictionary, and it still isn't in Oxford's dictionary, but I suspect many of you have heard the term. But for those of you that haven't, I just want to kind of say that in general, it is used interchangeably with terms like chemo fog, cancer-related brain fog, cancer-related cognitive dysfunction, cancer-related neurocognitive deficits, and cancer-related cognitive impairment. So don't be too fussed by what terms you hear if you're hearing people talk about it. The reason why I prefer the term cancer-related cognitive impairment is because the memory and attention or the other cognitive difficulties that we might see patients experiencing may not only be related to chemotherapy. So there are people who can have these symptoms who haven't actually had chemotherapy. And I'm going to present research today. I'm going to go over into some detail, some studies that have been done in lymphoma, and I think you'll hopefully have a better sense of what I mean by that. So cancer-related cognitive impairment is the term I'm going to be using, abbreviated to CRCI. All right, so what is CRCI and what am I going to talk about today? Kind of have three parts of what I'm going to say in terms of how I've organized this presentation. The first is to focus on the description. What is CRCI? What's experienced by people or what is observed, and when does that happen as it relates to cancer diagnosis and treatment? How is it assessed? And what's the impact it has on people? Then I'm going to move into talking a bit about the etiology. So why does it occur? What exacerbates it? What protects it? And finally getting into the evidence about interventions and treatments. What can be done to avoid, improve, or cope with it, even for you yourself, how you might self-manage it through education, supportive approaches. So back to the first topic, description. What is CRCI? Well, first off the bat, unfortunately, there are actually no diagnostic criteria for it. So this isn't something that you could go in to your doctor and say, give me a test for CRCI or chemo brain, or even to someone like me, a neuropsychologist who can do very detailed testing. I could certainly do those testing and I could say, oh, look, you're performing a little lower than we might expect, and it's probably related to your cancer treatment, but there aren't these established criteria to make that, quote, diagnosis. I have hope that that will come. I think part of this is because it is a relatively new field. Really, the research only began in breast cancer in the mid-1990s. So how is it approached? Well, there's kind of two main ways it's been assessed. The first is patient report cognitive function. So that's basically me asking you, how do you think your memory is? Give me on a scale of 1 to 10, where 1 is terrible and 10 is fantastic, how do you feel your memory is? So that is certainly very important thing to do because people are certainly experiencing themselves, but it does require that the person have some insight, right? You have to be able to remember what you don't remember in order to be able to make that judgment. Another way that it's commonly assessed and that I'm going to talk about is objective performance on, quote, neurocognitive tests. So these are tests that are standardized and we know, and there's norms. So basically we know how people should perform on those tests. Lastly, research has started, it's a relatively new way of looking at it, and that's looking at neuroimaging. So you can put someone in a scanner, like an fMRI machine, and you could have them do, say, a memory test, and you could kind of look at what their brain is doing during that test. I'm not going to be talking about any of the neuroimaging studies today. So first I want to talk about a review paper that was done, a really excellent review that was done specifically looking at cognition in all the different hematological malignancies. So this was children, this was adults, this was long-term, this was short-term, and this included the leukemias, the lymphomas, any of the hematological cancers. And what did he conclude? And this is only 4 years ago. Well, we know a little, but we really can't even be sure because there isn't enough evidence. And why was this? First, extremely few studies specifically on adult hematological malignancies. Studies have very small samples, so a lot of them were like less than 30 people, and we kind of want to see at least 50 people in a study to feel like it's got some reliability. In addition, the studies that had been done often combine people with different diagnoses and treatments. So it'd be hard to make conclusions when you've got breast cancer patients mixed up with lymphoma patients, for instance. In addition, all the studies at that time were cross-sectional. So people were assessed once, but there was no follow-up. So there was no way to know if symptoms get better or not. So and the last thing that group pointed out was that it was unclear if different cognitive domains may be affected differently. So yes, there's memory, but there's different kinds of memory. There's attention, there's visual spatial abilities, there's executive function. So executive function refers to things like your ability to plan, your ability to inhibit information, your ability to keep track of what you're doing and monitoring it, those kinds of switching between tasks. So that group, she made some recommendations for future studies. And specifically, she said there needs to be focus on Hodgkin's lymphoma and not Hodgkin's lymphoma because there was hardly anything in that. Second, they recommended larger sample sizes, so ideally greater than 50. Study people with the same disease and treatment whenever possible, so don't combine a lot of people together. Try to have the population as homogeneous as possible. And if possible, also include pre-treatment tests of cognition and longitudinal assessments so we could have a better sense of the trajectory. So that's where we were as of only 4 years ago. And now I'm going to present what has been done since then. And I first am going to show you a study that looked at patient-reported cognitive functions. Now you all know what that is. And this was published in 2019. It came out of France. And this was a web-based survey that was sent to a couple of thousand people. So good sample size. And about 1,600 people returned this survey. Fortunately, only 3% were hematological, but still it's a fairly healthy sample size. And these people were all post-treatment, and their average age was around 52. So what were the results? Oh, and post-treatment, they ranged from 2 months post-treatment to 32 years post-treatment. So quite a range. 75% reported having problems with memory, concentration, attention, finding words, either during and or after their cancer treatments. 35% reported that the difficulties started during chemotherapy. 30% reported that the difficulties started after chemotherapy. And the duration of difficulties were about 2 years. Although there was a really big range, some people said it only lasted a month. Some people said it was still going on. It never recovered. 75% not only reported these difficulties, but said that they had a significant impact on other aspects of their daily functioning. So getting back to work or school, social functioning, emotional functioning. So this is, of course, pretty compelling that these symptoms aren't just there as a problem, but they have an impact on people. Okay, so that was a fairly mixed bag of patients. Now I'm going to talk to you a little bit about more specific. So this was a study that came out just a little bit after that review paper, and this was looking specifically at non-Hodgkin's lymphoma during chemotherapy. And what they did is they compared two groups. One group had R-CHOP and one group had CHOP. They were average age of 43, and what they did is they gave them a cognitive screen 1 day before each of 4 cycles of chemo. Okay, so what is this cognitive screen? It's the mini mental status exam. It's really a screen to see how people are doing, and it's really kind of a dementia screen. It's sort of the older version of the MOCA, which you may have heard about it in the news back in July. Donald Trump was given the MOCA, and this is basically that kind of test. So it's really widely used. So what were those results? Well, first, the cognitive performance on this cognitive test was equivalent in the two groups. There was no difference between them. Secondly, results were all well within the normal range, so nobody was impaired. So that's good news. Thirdly, they still kind of expected some decline with chemotherapy. That was the hypothesis. And while they did notice a very tiny decline over time, so with each subsequent chemo, performance declined a little bit, it was not considered, and it's not considered clinically meaningful. Okay, so that's fine. However, it sounds like, oh, no problem in these patients. But in fact, the main question is, was that test sensitive enough? And the answer is no. Cognitive screens are not sensitive enough for CRCI. Plus, you need a control group. What did people look like who say don't have the chemotherapy? So this is a figure to kind of illustrate this. What you're looking at on the right, I'm going to direct you to the y-axis. This is performance, a score. So higher score is better. And what you're seeing here is testing immediately before and immediately after each cycle of chemotherapy. So 1 day before the first cycle, and then right after, the day later, and so forth. And what you see in the mini mental is over each subsequent test, there was equivalence, right? So no change over time on this test. In contrast, down here, you have a verbal learning test. It's called the HVLT. That's not so important, but it is a very sensitive measure of verbal learning. And what you can see here, when these same participants are given this study, are given this test, you can see big changes. So immediately before their first cycle, they're performing fine. This is actually well within the normal range. And then they go down first cycle. Then there's recovery. Between cycles, their cognition improves, then there's decline, then they recover, and then they go down. So this is where it's really important to know if you are reading about a study or you hear, oh, there is no effect, you have to kind of know, is that test sensitive enough? You also might want to know, well, how do these people do if they aren't given any chemotherapy? So this is what I'm showing you. This is controls who are given chemotherapy. How do they do on this verbal memory test? So the first time they're given it, they do just as well. But every time they're given the test again, they improve, which of course makes sense because they're learning. There's something called like practice effects or repetition. They're getting the same memory test over and over. They are going to be learning. So you can kind of see that even this person here, at the beginning of their third cycle, it looks like they fully recovered. They are performing below what you would expect. So for the rest of the studies I'm going to review in terms of the evidence, I'm only going to be looking at those studies that have a control group. So let's look at younger people. Now, there is some ideas in the field that older people's brains may be more vulnerable to the effects of chemotherapy. So we kind of want to look at people depending on how old they are. So this is a study that looked at younger Hodgkin's lymphoma survivors, about 50 of the patients, 14 controls. The average age was 28. And these people were between 6 months and 5 years post-chemo. So nothing really acute. And what were the results? Well, first, when asked how their cognitive functioning was, the patients or the survivors reported far more problems in their everyday cognitive functioning than did the healthy controls. This was highly, highly significant. What did the objective test show us? Well, they also showed that the Hodgkin's lymphoma patients performed lower than the healthy controls, particularly on tests of memory and executive function. So again, to remind you, memory is things like memorize this list of words. So I'm going to show you some pictures. Executive function is things like planning, executing, multitasking, dividing your attention, that kind of thing. Interesting, there is something that we kind of think of as a dose-response relationship, possibly. So of the patients who received full 6 cycles of their chemotherapy, 30% of them performed in what is considered a clinically impaired range. So not just that they performed lower than the healthy controls, but they were quite a bit lower and they were in an impaired range. Those that had only received 4 cycles, in contrast, only 13% of them performed in the impaired range. So it seems to suggest that the more chemotherapy you have, the greater the chance you have of having a persisting cognitive impairment in memory and executive function. So that was younger people. How about middle-aged people? So these are 2 studies, quite very similar to each other. This average age was 47 in this study, and this was combined non-Hodgkin's and Hodgkin's lymphoma survivors. There were about 106 people in the study, and these were 2.5 to 6 years post-treatment. And what you saw in this study is that test performance overall, the groups were equivalent. So the lymphoma survivors performed as well as the healthy controls overall. However, there was a greater risk, or there was a greater chance that the lymphoma survivors would score in an impaired range. 16% scored in an impaired range. Another study, very similar, also looking at middle-aged, age of 50. These people were there was a broader period of time since treatment. So the earliest was 4 months since treatment, all the way to 5 years treatment. And what were those results? Well, patient report, again, consistent, that the survivors of lymphoma who had had treatment were reporting significantly more problems. They also found that the extent of their weakness was highly correlated with fatigue and anxiety. So in other words, people who also suffered from anxiety were more likely to have cognitive complaints. They were reporting more memory problems. Now, what do the objective cognitive tests look like? Well, just like we've seen in the earlier studies, the healthy controls perform better than both Hodgkin's and non-Hodgkin survivors in the areas of attention and executive function. And in this case, that performance was correlated with pain. So in other words, people who are suffering from pain actually do worse on cognitive tests than those that don't. In addition, 30% of the lymphoma survivors fell in a clinically impaired range in memory and executive function. So again, that memory, executive function is coming back again. Last study like this I want to tell you about is with older people. So what about older people and longer term survivors? These were non-Hodgkin survivors. The average age of these people were 74, and these people were between 5 and 17 years after treatment. So what were the results? They only looked at neurocognitive tests, and like in the previous tests, the non-Hodgkin's lymphoma survivors had significantly lower performance than their age-matched peers that didn't have cancer or treatment for it in attention, verbal memory, and executive functioning. And they took it a step further and looked specifically to control for any confounds related to comorbidities or medications. And this difference held even with that control. Okay, I want to make it clear that most of the research has in fact been done in other cancer patients besides lymphoma. Breast by far and away is the most common, but it's been looked at head and neck cancer, colorectal cancer, testicular, gynecological cancers, multiple myeloma, prostate, thyroid, lung. I'm not talking about brain tumors in this presentation, so I don't even have that included. So given all of those studies, including that of what we know in lymphoma, this was a conceptualization, a picture that I thought was really nice. It was just published a couple of months ago, and it's talking about the trajectory. So what should we expect over time? And what you see in the y-axis is cognition, where higher is better. And you've got like the normal range up here in white, and down here, the beige is impaired. And on the x-axis, you have time. So first look at this grayish line. This is indicating normal aging. So sadly, as we age, there is a slow, kind of steady decline. That's called normal cognitive aging. Compared to that, we've got what he's calling chemo brain, or I would call it CRCI, and that's in red. And what you see after the onset, there is this increased decline over time with each subsequent chemotherapy. And then after chemo stops, there's some recovery, it plateaus, and then there's some decline. What the slope of this is remains to be determined. Is it parallel to normal aging? Is it more? We don't know yet. That's yet another field of study and studies that need to be done. I also really like this figure because it puts some other things in context, like look at it compared to traumatic brain injury, where you see a much sharper, extreme severe decline. You see a really rapid recovery, but it never goes even approaching normal aging. And then here in pink, we've got depiction of Alzheimer's, which is of course a much steeper slope than normal aging. It's neurodegenerative. It's continuously going down, unlike chemo brain, which has this recovery. The pattern, what we don't know, and I mentioned this already, we don't have the details of the functions, like how long is this down here? How high can this go? those kinds of details of this function. We do not have that yet, unfortunately, but there's a lot of research being done, and hopefully we'll have those answers. So summing up what I've told you so far, what's the consensus to date in terms of describing CRCI? Well, up to about 30% of chemotherapy-treated adult lymphoma survivors, both non-Hodgkin's and Hodgkin's, experience persisting cognitive impairment. That means 70% don't. So there is that flip side of that. The cognitive domains impacted are attention, memory, and executive function. And if you have more questions about what those mean exactly, I can certainly take those at the end. Patients can have cognitive deficits pre-treatment. I didn't talk about this, but we know that to be the case. That could be the effects of the cancer, your body responding to the cancer, and the distress. That being the case, however, CRCI is most severe while on chemotherapy, and the particular characteristics likely depend on cancer type, treatments, and other non-modifiable factors. So when I talk about non-modifiable, I'm talking about the things that you can't really do anything about, such as your genetics, such as your pre-cancer conditions that may have nothing to do with cancer, and or comorbid conditions. So a lot more research is needed. So now moving into the kind of middle part of my talk, and that's about the etiologies, so the causes, the risk factors, and so forth. So treatments obviously are what we generally think of as being the main contributors to CRCI, and certainly chemotherapy has been far and away the most studied. But there may also be effects of surgery, if that is part of your treatment, radiation, hormonal drug therapy, stem cell transplant, immunotherapies. I have question marks there because there's hardly been anything done yet to know whether those have associated risk factors on cognition. Let's move into the modifiable factors that may exacerbate CRCI. So although these factors may not be the primary cause, they can make it a lot worse or may put a person more at risk of experiencing it. So that can include stress, anxiety, depression, disrupted sleep, pain. We sort of saw that in a previous study, as well as with anxiety, thyroid problem if it's not managed, low B12, for instance, if that's not addressed, those can exacerbate it. So this figure is sort of a complicated or more thorough and complete picture of what I kind of just told you. What are the potential mechanisms and risk factors? So this was published just a couple of months ago. You've got cancer and chemotherapy leading to chemo brain via these other mechanisms. So neurotoxicity, neuroinflammation, oxidative stress, and so forth. I am not a biochemist. I don't understand this very well, but I know that people talk about the intermediate mechanisms having to do with possibly things like vascular damage, reduced neurogenesis in the brain, so the creation of new brain cells, and so forth. And then over here, we've got some of those other things I already mentioned. There could be genetics, you could have a thyroid problem, your hormonal status, other, because who knows what else. And then over here are the kind of non-modifiable factors or modifiable factors that, again, can play a role in this, quote, chemo brain or cancer-related cognitive dysfunction. So let's dive a little bit more into the modifiable factors that can protect, because this is then leading to the third part of my talk, which is about interventions. What can be done? So this is an animal model that Gordon Lineker did. He's did this out at Trent University, and his question was, can physical activity protect against chemotherapy-induced cognitive impairment? So this is specifically chemotherapy-induced because these animals did not have cancer. And the question, this came up because there is evidence and research in normal aging that physical activity can help delay cognitive aging. So what he did was he put rats in cages that were either had a running wheel or did not have a running wheel. For those of you who don't know anything about rats, they actually like to run. So when you put them in a cage with a wheel, they'll use it, okay? And they were there for a few weeks, and then they were received 3 weekly injections of chemotherapy, okay? And half the rats received the chemotherapy and half the rats received an injection of a saline solution. And then after the 3rd cycle of chemotherapy, all rats had to complete tasks of learning and memory. Every single day they had to come and do the same task every day for 10 days. And the question is, how do they do on this test, and do they get better at it over time? And here are the results of that. So let me orient you. The y-axis is errors. So higher is worse. Okay, the x-axis is days, or how many days, how many times have they done this task? Okay, so what I want you to look at first is the green. These are the rats that did not have chemo and were in the exercise condition. So they had a wheel in their cage. And you can see they all roughly start around the same, and they learn very quickly. Even from the first day to the second day, their errors decline, and they keep declining. By day 4, they're already at the best they're going to do, and they continue. And this was virtually indistinguishable from the rats that had chemotherapy, that also had access to the wheel. You can see they also learn quickly, and then they continue. In contrast, look at this red. The red indicates or represents those rats that had the chemotherapy but did not have access to the wheel. There was no exercise. And look at their ability to learn. It's terrible. They are not getting any better. Day 1, day 2, day 3, day 4, day 5. They just keep making the same mistakes over and over. They're not learning. They're not remembering the experience from the days before. Eventually, by day 7 or 8, they eventually learn a little bit, but even by day 10, they are never reaching the level of performance that the other 3 groups reach. This blue line is kind of interesting. These are the rats that didn't have chemo, but also didn't have a wheel. So they were also not exercising. And you can see them, they also are not doing as well, right? Eventually, though, by about day 4, the 4th time they do it, they do eventually learn and they do catch up. So what is this telling us? At least in rodents, exercise, physical activity, maybe cardio, running, if you want to make it try to be parallel, is protective against the chemo brain that you might see specifically related to chemotherapy. So next experiment I want to tell you about, very similar. This time his question was, can social engagement or environmental stimulation possibly also be protective against chemotherapy-induced cognitive impairment? So some rats were housed in the regular cage, and some were in this enriched environment cage. So these rats were housed, number 1, with each other. They had playmates, and they had lots of toys. So they had balls to go around, they had tunnels to climb through, levers to manipulate. And again, same experiment as before. The 3rd cycle of chemo, they're given a learning task. Again, errors are on the y-axis. Higher is worse over time. And what I want you to look at is how different the rats that received chemo but were isolated compared to all the others. So those rats that received chemo that were not in that enriched environment have a really hard time learning. Clearly, chemotherapy is impacting their ability to learn. Eventually, by day 4, they start to learn. All the other rats perform the same as one another. No significant differences. Again, being in this environment masked or protected the learning ability in these rats, even when they had chemotherapy. So back to this figure, it's the same as before, but now what we've done is added What are the possible treatments and protective factors? So I've got stress reduction management programs, physical activity programs. There's also preclinical studies that I'm not going to talk about. And then there's randomized controlled trials, repurposing existing medications. So what do we know so far about those? So first of all, nearly all of those have been done in breast cancer. I'm not aware of any that have been done in lymphoma as yet, but this is what we know. The randomized controlled trials for drugs or supplements for CRCI, so far, none show significant effects. So they've looked at psychostimulants like drugs that are used for attention deficit disorder, as an example, medications for sleep, fatigue, Alzheimer's medications, depression, anxiety like SSRIs, ginkgo biloba, etc. Nothing significant so far, but this is an area of active research. What has the strongest evidence, and again, this is in people now, in actual cancer patients, not in rats, physical activity, physical exercise programs have been shown to both protect against chemo brain as well as improve recovery from. There's also strong-ish evidence of the benefits for cognitive retraining, psychoeducation programs, cognitive behavioral therapy, mindfulness-based stress reduction, meditation, yoga, qigong. We don't know whether the yoga, qigong, tai chi is having its benefits via physical exercise or if it's via relaxation. We don't have that information, but we know it looks to be beneficial. I often get a lot of questions about, brain games, computer-based brain games. There have been a lot of studies trying to look at that. And so far, there's very limited generalization to those being helpful. So basically, you'll get better at the tests that it's testing you on, but it doesn't translate into sort of your everyday functioning. So now I've kind of, in addition to exercising and staying stimulated, what can you do in the everyday if you're someone who right now feels like you've got some symptoms? Well, first, use external memory aids. So a lot of these, I think, are probably fairly intuitive, and I suspect a lot of you use these things already, but it's just reminding yourself that these kinds of things can help avoid those mistakes. So use timers and alarms, use your calendar, check it, write things down, use your cell phone voice memo feature, take pictures with your cell phone. If I could see you all, I'd be asking you, everyone raised their hand who does some of these things, and I suspect everybody does. Another tip is to be mindful. So to be aware that if you're not focusing on what you're doing or what's happening, you're not going to be able to remember it later. So this really becomes about pay attention to what you are doing as you're doing and ask yourself, what am I doing? Am I doing what I intended to be doing? And if you can't remember what you were intending to be doing, check your list. Sometimes it's helpful to speak out loud when you do this, to say out loud what it is that you want to remember. Slow down. We tend to make mistakes when we feel rushed, and avoid multitasking. So really focusing on one thing at a time. If you're doing task A and you can't finish it and you have to switch to task B, that's fine, but do it intentionally and then put in some support to help you remember that you've got to go back and finish task A. Reducing noise and unnecessary interruptions. Noise makes it hard to focus on what we're doing. Interruptions, it's very effortful to disengage in something and then have to re-engage back to it. So when possible, reduce that. So for instance, turn off your television if you're reading, turn off your non-essential phone and email notifications if you're doing something, because those little pop-ups are going to be a distraction and take your focus away. And it is more effortful. This is just kind of about staying organized, decluttering, keeping a routine. I have a lot of people say just looking at that picture makes them stressed. So if that's you, it's important to kind of take that into consideration. So setting up a regular daily routine, take your medications at the same time every day, keep your keys in a small bowl by the front door on a hook, just so you're not having to remember, where did I put them last? So create a system, and if that system works for you, stick to it. Some people talk about making a list, to-do list in the evening before for the next day. That helps them feel more organized. A lot of times using physical organizers, so baskets or colored folders, envelopes, letters, clips, that doesn't do the organization for you, but it is motivating to, in fact, put things back where they belong if they have their own special place. I'm a big believer in using a pill organizer or a dosette to organize your medications for the week, even if you only take one thing, right? Just so that you don't have to say, oh, wait, did I take that or did I not take that? Repeating and reviewing. So this is like being back in school. You know, you need to, if you're having trouble with your memory, you need to put more effort into this. And that might mean if you hear something, say it back right away, repeat it. If you're reading, read it a second time, read it a third time if it's important. If you're writing things down that you want to remember, then review those notes. Think about what happened during the day and what you learned from it. So you're attending this session, you're attending this conference. How well are you going to remember some of the things that you, as you were listening, you're like, oh, that was really interesting. I hope I remember that. If you don't think about it again, a month from now, it's going to be really hard for you to remember that. But if today you go home, or you're already home, but later today at dinner, you think, oh, what did I learn today? What was interesting about that conference? And you actually think about it again, you're much more likely to hold on to that information and be able to remember it tomorrow, next week, and so forth. Taking this to another level is what I call a delight diary. So that's writing down details of neutral or a positive event that you experienced during the day that you want to remember in the future. The more descriptive and vivid of your observations are, the more vivid your recollection will be of that event. And what's nice about this activity is it works the memory parts of your brain. It practices word finding because you have to be writing it, practice your spelling, and then you have that record to look at should you need it. Or you just want to look back on what good things happened to me last week. So what are my take-home messages? Well, CRCI is unfortunately a potential side effect that sometimes persists. The severity of it and the timeline of improvement is not the same for everyone, and we can't really predict who's going to have it bad and who isn't. We don't have enough research yet. My prescription to you to minimize and manage it, should you have it, is to maintain or increase physical activity if possible. Seek referral to a physical therapist or a kinesiologist with oncology experience or expertise if that's available in your community. Maintain socializing and other pleasant, mentally engaging and challenging activities that are meaningful for you. Of course, with COVID, socializing means something different because everything has to be done safely. So you have to kind of keep that in mind, of course. Stress reduction activities and techniques are very important as well. So whether that's formally taking a relaxation course or doing a breathing exercise every morning, or that's going out and sitting in a park bench and looking at the leaves changing colors in nature, or listening to music, whatever it is for you, so that every day you can have an active relaxation. So I'm not talking about a nap. I'm talking about you actually are awake, yet it is relaxing and reduces stress. And then finally, the compensatory kind of workaround strategies that I just went over, the tips to really just reduce the mistakes that you may be making, which then, of course, can be stressful, which is why it's nice to make fewer of them. So if you're interested in more kind of concrete information on this, I've worked with the Princess Margaret Patient Education Department, and we've developed the Cancer-Related Brain Fog booklet. It's available in English, Portuguese, and Chinese. In addition, there is what we call an e-module. It's kind of an online class, and that's at this website, pmcancerclasses.ca. You can look for the Cancer-Related Brain Fog. There are others available. What's nice is this is not specific for Princess Margaret. You don't have to be a patient at Princess Margaret. You don't have to be referred. You can access these things from anywhere. And that's the end of my presentation. Thank you for listening, and I'm happy to try to answer questions if there are any.
Thank you so much, Dr. Bernstein, for such an incredible comprehensive review and also for sharing very, very valuable strategic strategies and interventions on how to address cognitive impairment. So with that, I would like to open it up to our attendees. There's a question and answer text box at the bottom of your screen. If you have any questions, please put them in there and I will read them out for Dr. Bernstein to answer. Could you talk a little more about how can patients advocate for themselves and who do they ask their questions and concerns to either before, during, or even after their therapies?
Yeah, that's a good question, right? Because it you know, depends on where you are and where your treatment is. Like I can tell you what you do at Princess Margaret, but that's not necessarily helpful for everyone else. I mean, what you want to do, I would say, is that certainly if you are before treatment, right? Like, so there's a new kind of push in this. Instead of thinking of rehab, we think about prehab. So what can you do leading up to treatment? You want to be in as good of shape as possible. You want to have as many of these systems in place to help you. So that's all kind of self-management part, right? Because unfortunately, there are no medications to fix this or prevent it, right? So your physician isn't going to be able to, or your oncologist there's nothing to prescribe along with it. That being said, it is important to report those things to them as it's happening, just because that can give them a sense of, are you having an unusual reaction? Right? So certainly if anything is sudden or severe, that would be a little bit more of a red flag, unless you're like in the middle of chemotherapy right then. Certainly if there's changes in like personality, that is less common, right? If family members are noticing it more than the person themselves, that's also less common. So again, if the patient themselves is like, oh my gosh, I can't remember anything, what's wrong with me? That's kind of really very typical. So it would really be about monitoring that. And if things seem unusual, to bring that up, right? So sometimes occupational therapists, like it's hard to know what's available. Like, so certainly I see people, but that's in my clinic for that. That's why I mentioned these resources. But if you think there's something else going on, that's when it's really important to speak to your doctors, because they can, occasionally it's something fairly simple like, oh, really low B12. And then with supplements, that can help resolve it. So it's also sometimes for the physician's sake to rule those kinds of things out.
Absolutely. It's great. Another question that has come in is how best to explain to doubtful people and relatives about the challenges?
Well, it's real. If nothing else, like I like to say to people, look, they've hired me. I'm doing this for my job, right? The hospital is real. You can certainly, print out that information, like the booklet that I mentioned, and you can actually give it to people if this is people that you're with. I mean, a lot of people do kind of say things like, oh, that happens to everyone. They're sort of like that. And it's like, well, yeah, maybe, but not that sudden and not to that extent, right? So it's about trying for you maybe to also figure out what you think would help you. Like, what are the conditions in which you feel like you're performing pretty well? What kind of supports help you perform well, instead of focusing on like, ooh, when I'm in this situation, I make lots of mistakes. Well, what could I do to try to avoid that? So if you're trying to handle maybe family members who are not feeling like you're just not trying, that kind of thing, you could kind of think about, well, this is what would help me not make these mistakes. That kind of,
hopefully. Yeah. Absolutely. We actually are out of time, but I want to take one very quick question. For those whose questions we were not able to answer, please email us at info@lymphoma. Sorry, I actually forgot the email address. Sorry, info@lymphomacanada.ca, and we'll pass your questions on to Dr. Bernstein. But a very quick question, Dr. Bernstein, to wrap this up with: are cardio classes better than walking outdoors?
Oh, I would say whatever you can do is do it. I mean, there has been research about indoor track versus going outside, and outside actually is better. So that might be because the outside is more in nature, and that's, you know, there is something to the grandmother wisdom of go out and get some fresh air. So
Excellent. That's perfect. Well, thank you so much, Dr. Bernstein. We're very grateful for your time and your expertise today. We had such an incredible session.